Good afternoon, everyone. Welcome to Ethics for Lunch for February. As you all know, this is a monthly session where we engage with the hospital community about issues in clinical ethics, things that might be relevant to those working in the hospital, as well as our patients and families in the community. And this is a session that's sponsored both by the Johns Hopkins Ethics Committee, as well as the Berman Institute of Bioethics. I'm Mark Hughes. I co-chair the Ethics Committee with Cinda Rushton. The Berman Institute also sponsors a Masters of Bioethics program. And if you're interested in learning more about that, we've had several faculty and staff and students that have enrolled in that in the past few years. Excellent opportunity to learn more about bioethics and get some training, potentially make it an aspect of your career in the future. For those that work at Hopkins, there is an opportunity for tuition remission for that. And then in the 2023 and 2024 academic year, there's an opportunity for scholarships for covering 20% of the tuition. It's a program that you don't need to do the GRE for a master's level program. And if you want to learn more about it, there's both the Berman Institute website, as well as we'll put in the chat an opportunity to learn more, the link to information about it. For today, if you're interested in continuing education credits through our CME office, we have it at the top of the screen there, the 443-541-5052. If you put in the code 43693, that will get you the credit, and we'll put that in the chat as well. Today's topic is going to be the ethical issues related to determining death by neurologic criteria, and I'm going to turn it over to April Sharp, who will lead our discussion.
Hi, everyone. Thanks for joining. My name is April Sharp. I am a pediatric neurologist with a special interest in critical care, especially brain death. And I'm going to be the moderator for today. We've got a wonderful panel of speakers and colleagues who will be talking about a sample case, as well as some discussing questions. Before I introduce them, these are our learning objectives. So we're going to review the definition of death by neurologic criteria, as well as the process of determination. This is outlined in a new health system-wide policy that becomes active this week. Explore how multidisciplinary care team works together to help families understand and cope with their loved one going through the process of death by determination of death by neurologic criteria. We hope that you'll know what resources are available to you and to families, as well as the next steps, as if a family is not in agreement with the evaluation or determination of death by neurologic criteria. And then to recognize that families are grieving throughout this process and be able to provide the appropriate support and some resources to do so. So I would like to have our panel introduce themselves. We'll start with Dr. Ivor Berkowitz.
Hi, good afternoon, everybody. I'm Ivor Berkowitz. I'm a pediatric anesthesiologist and intensivist. And a affiliate faculty member of the Berman Institute. I have a long-standing interest in the ethics of brain death, and I'm a past director of the pediatric ICU. I'm currently not practicing critical care right now.
Thank you. Next we have Emily.
Hi, I'm Emily. I'm a nurse practitioner with the pediatric palliative care team, but I'm embedded in the PICU. I've worked with Ivor for many, many years.
Matt Norvell will be joining us as soon as he is available. He's one of our pediatric chaplains who works in the pediatric ICU. And Dr. Lisa Sun.
Hi, everybody. I'm Lisa Sun. I'm a child neurologist, and I have the pleasure of working with Dr. Berkowitz and Emily in the PICU on our neurologically critically ill children.
Okay, and Matt,
April,
can you?
I'm here.
Oh, good. I couldn't see you. Great.
Yeah.
Matt, can you introduce yourself?
Yeah, I'm Matt Norvell. I am a pediatric staff chaplain, and I have been working in the Department of Pediatrics for a bunch of years, also with the palliative care team. And I'm also a member of the ethics committee for the hospital.
Great. Thank you all. So very quick background on death by neurologic criteria, also commonly called brain death. This was first introduced as a term in 1968 and defined as irreversible coma, with some criteria listed, although those have changed over time. And then in 1980, we had the introduction of the Uniform Determination of Death Act, which is a law that has been adopted by many, but not all states, that stated an individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. A determination of death must be made in accordance with accepted medical standards. Following this, multiple clinical guidelines have been adopted over time in both adults and pediatrics. The current pediatric guidelines were established in 2011. They're reviewed every 3 years, but have not changed in that time. But this year, we are expecting that there will be both an updated version of the Uniform Determination of Death Act, as well as updated guidelines that incorporate both adult and pediatric criteria into one guideline. So this is something that is of interest to you. Looking out for that. We're all waiting very expectantly. So we'll go on to our sample case. Now, this case is a representative case, but is not based on any particular patient, but highlights many issues that we often encounter in neurocritical care in the pediatric ICU. So this is an 8-month-old girl who's admitted to the pediatric ICU after a high impact motor vehicle collision. She was ejected from the vehicle. She was found nearby unresponsive and pulseless. She got CPR, which was performed for about 30 minutes, and they did get return of spontaneous circulation. She was transferred to the hospital. On arrival, imaging showed multiple injuries, including intracranial injuries and concern for anoxic brain injury. On her initial exam, she was noted to be comatose. She had a few brainstem reflexes that were present and occasional extensor, posturing, straightening of all of her extremities, but didn't have any purposeful responses or movements. She got maximal neuroprotective measures, but over the next 48 hours, she no longer had any brainstem reflexes and did not demonstrate any response to noxious stimuli except for triple flexion reflexes. An MRI was obtained and showed extensive anoxic injury with evidence of brainstem herniation. And her care teams are now concerned that her exam is consistent with death by neurologic criteria or brain death. Her father unfortunately died in the accident. It was the two of them in the car. Her mother has been at the bedside since she has arrived in the PICU, and there are both sets of grandparents have been there. Upon hearing that she has irreversible brain injury and might meet criteria for death by neurologic criteria, they understandably become very emotional and upset. Her mother says, "That's not possible. I see her move her leg when I touch her. She knows that I'm here. She's responding to me. I can't lose her too." And the family expresses that they don't want the team to do an examination for death by neurologic criteria because they think she's going to get better. She just needs more time. So considering this case, we want to explore a few different aspects. So the first question is, what is death by neurologic criteria? How do we define it? And how does this process of determination differ from a more common conception of death or death by cardiac and pulmonary criteria? And Lisa, can you start us off?
Sure, thank you. So, as April mentioned early on, legally, death is defined as irreversible cessation of either cardiorespiratory function or neurologic function. And so when we're thinking about death by neurologic criteria, we're specifically thinking about absence of any clinical brain function. And what is sort of embedded in that is that we understand why this has happened, and we know that it's irreversible. We have to make sure that when we're evaluating for brain death, that there's no complicating medical conditions, intoxications, or other abnormalities that might be contributory to the exam. And we also have to make sure that all the therapies that might help have been performed appropriately or are not appropriate. So when the kind of process that we see in a practical purpose is that the primary team, which is often the PICU team, develops a concern for death by neurologic criteria, and then they'll kind of engage the neurology team in starting to think about that process. And early on in the process, we obviously start to talk with the family, talk about what we're seeing, and prepare the family, and really work with them on sort of the timing of this process, and making sure that we're supporting the family in the best way possible. And that's something we don't wait until we declare the patient brain dead to do. We're starting that as early as possible and engaging a lot of our colleagues for that. In general, death by neurologic criteria involves 2 examinations, and they have to be a certain time apart, and that depends on the age of patients. So for adults, the 2 exams have to be at least 6 hours apart. For children a month and older, they have to be 12 hours apart. And then for full-term babies up to a month of life, the 2 examinations have to be at least 24 hours apart. And we can perform the first exam as early as 24 hours after the insult or the CPR was administered. So when we kind of get to that point, the first thing we do is check to make sure that all the prerequisites are fulfilled. And I definitely want to give a shout out to the policy that April mentioned is effective as of this week. All of the prerequisites are really laid out very nicely. And I will say I've been doing this for a while now, but I always print it out and check it and make sure that we're really being very methodical about it. And it's nicely laid out in that policy. But in general, what those prerequisites are going to entail is, first of all, that you look at the medical record, you understand what happened, you look at all the neurologic imaging that you have. And really what you're trying to answer with those questions is there both clinical and radiographic evidence of a catastrophic irreversible brain injury? Then we're looking at all of the lab studies, drug screens, and medication administration record to look for any complicating medical conditions, abnormal labs, or potentially pharmacologic agents in the system that could confound our exam. And then we look at our vital signs, making sure that the temperature is normal, the patient's not very hypotensive. And this is really all just to ensure that when we're doing our clinical brain death exam, that there's nothing outside of brain death that could be causing our exam. And then we get to the exam, and the logistics of the exam are basically 3 major things we're looking for. The first thing is we want to confirm that there's truly coma, the patient's truly unresponsive. And what that means is that there's no response at all to various types of noxious stimuli. And we're looking at both motor activity and autonomic responsiveness to those things. Something that's important to know is that there are some reflexes that can be present in brain dead patients. Things like triple flexion, as was an example in this case, and that's something we see commonly, and is really important to sort of not only be aware of, but also educate family about that there are some reflexes that are spinal reflexes and not indicative of brain function. The second part is brainstem reflexes, and so we'll go through all of our the brainstem reflexes that might indicate that there's some brainstem function. So things like pupil reactivity, cough, gag, things of that nature. We have a very systemic way of going about looking at all of those things. And then the last part is an apnea test. So we really want to try to increase the partial pressure of carbon dioxide and really try to stimulate the patient to breathe and see if there's any respiratory drive available. And then occasionally, if one of those tests is not able to be interpreted, and that could be for various reasons, we will do an ancillary test. But in large part, the death by neurologic criteria is a clinical determination. And so after we do the first test, if it's consistent with brain death, then the second test would be pursued after that interval of time. And then after that point, the patient would be legally dead by neurologic criteria at that point.
Thank you, Lisa. Ivor, can you talk about how this process differs from our more common conception of death or cardiac death?
Yeah. I just wanted to add one little bit of information about the UDDA and our definition of death. And the point I want to make is that when this whole concept of brain death and the original proposal for brain death goes back to the mid-60s, and the UDDA, which came out in 1980, was a sort of a development and incorporation of that very early bits of information that were published in 1960. And at that time, it was generally, and sort of why this all came about was that, with the development of intensive care units, there was a group of patients who formerly would have died if they were not resuscitated, would have died without ICUs, without ventilators, without drugs that supported the heart. And these patients would have died by the old cardiac death, the biblical sense of dying when your heart stopped and you stopped breathing. With ICUs, we now were producing a population of patients whose heart and lungs were working, but as Dr. Sun mentioned, whose brains were no longer functioning. And this is sort of where we see ourselves now. In past, it was generally assumed that those patients who were declared brain dead or dead on the basis of neurologic criteria, over days or some few weeks, their heart would inevitably stop. So there was, in essence, almost like a final common pathway of death from a that ended up with cardiopulmonary or cardiac cessation. Nowadays, with more modern ICUs, many patients who are brain dead, if the ventilator is not withdrawn at the time of declaration of death, can continue with cardiac activity. So I just want to then move on to the difference sort of in how the process works. The process for diagnosing cardiovascular death or cardiorespiratory death is really much more simple, and I'm sure you're all familiar with it. This is essentially diagnosing the cessation of heartbeat, which we do by feeling for a pulse. There's absent pulse. Nowadays, most of these deaths, or many of these deaths, occur in hospital. These patients are all monitored, so we will see a heart rate that slowly slows on an EKG monitor and then stops. We're familiar with the term flatline that we see in medical TV shows. And that's what that is. The heart is stopped. We, from a clinical point of view, would listen to the heart for a heartbeat. We would look for movement of the chest and breathing. We would listen to the chest to see no breath sounds. We would also then check for the quick manifestations of the effect of this on the brain. And not that we would at this point do a formal brain death, but we would look at the pupils to see whether there's reactivity. Sometimes it gets more little more complicated with these very fancy resuscitation techniques that we have in the ICU with ECMO, which can take over the function of an arrested heart, and we can use another technology, that of a cardiac echogram, to see exactly what is happening to the heart. And so that sort of covers the spectrum of how we would diagnose cardiac arrest. The issue of how this compares with what Dr. Sun was talking about is very different. The process of making a diagnosis of death on the basis of neurologic criteria is usually a much more protracted one. Patients will come into an ICU. They're on a life support at that point with a ventilator, maybe with drugs to support the heart. And then it's over a course of whether this is hours or days. But the clinicians who are taking care of this patient would note that, this patient doesn't seem to be moving. Patients are assigned a Glasgow score. When patients sort of reach a very low Glasgow score of 3, there's concern. Well, maybe, this patient has in fact lost all neurologic function. Patients are examined repeatedly in an intensive care unit from a neurologic point of view. They're examined when they come in. They're examined by their nurse several times a shift. And so one would become aware that whereas previously maybe the pupils were reactive, now maybe one is not reactive, and then a couple of hours later, maybe both are non-reactive. The nurse may notice that when she passes a catheter down the endotracheal tube to suction out secretions, that, an hour or 2 hours when she did the last one, the patient was coughing. Now the patient is no longer coughing. So this evidence sort of builds towards the fact that, well, really maybe this patient is brain dead at this point. And this would then sort of trigger the initiation of a very formal, what we refer to as a brain death examination, I think the ICU attendings and staff would do a preliminary exam. They would go through the maneuvers that Dr. Sun sort of mentioned, or many of them, and then, have a sense, wow, this patient, we think maybe brain dead. We should ask our neurology colleagues to come and perform a formal brain death exam, as Dr. Sun mentioned. So you could see this whole process, takes much longer. It's often, and it's associated with this progressive loss of neurologic function, usually.
I think that's a great segue into our next question. Once there is concern about possible death by neurologic criteria, how is this topic, this concept, introduced to families and communicated to them? And how do all of you as members of the care team work with the greater care team to help families understand what death by neurologic criteria means and what will happen, what they might see throughout the examination? And maybe, so you would be taking care of the patient, seeing that they have declined and concern about absence of neurologic function. How would the ICU team begin the introduction, and who would you then involve?
Yeah, so I think an important thing about this whole issue is that a discussion about prognosis in a patient with a severe head injury, or after a cardiac arrest and a hypoxic ischemic insult, a discussion about possible prognosis, possible outcomes, how the course of the ICU stay should be begun very early in the course. You know, in the patients we see, the patients will often come in, you know, brought in by paramedics after an accident like this. They initially seen in an emergency room and stabilized, and then brought up to the ICU. And that's where the ICU staff would meet the family. You know, I think right up front, clearly one needs to be enormously sympathetic with this family who have gone through just an unbelievably horrible experience. In this case, the child's father has died. The mother is there, maybe with the support of family, and you know, just is totally overwhelmed. So, you know, at that point, maybe it's not quite appropriate to talk beyond the immediate medical care. But, you know, later in the day, or perhaps the next day, one, you know, well, and early I think is preferable. I like to sit down with a family. I think it's very important for the you know, the medical staff, the residents, perhaps and the fellows to be there, as well as with the patient's nurses and a social worker. And you know, this can be done in the patient's room. It can be done in a conference room. And I think one needs to start, as I said, is talk about prognosis, present a range of clinical outcomes. You know, and by that time, scans have been done, and we have a sort of a sense of, you know, is this going to be a pretty mild injury, a moderate injury, or if this is going to be, you know, really very severe. And those are the sorts of paths that we would discuss with the family. And, you know, if it looks really very bad, I think even at this point, one can lay open the option that, you know, that their child, you know, so sadly has been so terribly injured. And even relatively early in the course, it may make sense to raise the possibility that this may not be a survivable injury. And, you know, as the, you know, hours go past, one might, you know, we would sort of meet with the family again. And if it's looking like, you know, the neurologic function is slowly being lost, or it may be after the sort of exam that I mentioned earlier, where we see now that the pupils are no longer reactive, the child is no longer moving. We haven't taken the child off the ventilator, but we see that the child is breathing at the same rate as the ventilator and not making independent movements. You know, as part of our sort of not formal brain death exam, but as a part of our brain death, as part of our neurologic exam, we find that there are many of the features of a brain death exam that are that those functions have been lost. At that point, you know, I find it useful to explain how, with the advent of modern ICUs, that for the past 50 years in this country, when patients have lost all neurologic function, that those patients have died on the basis of their brain injury, even if the heart hasn't stopped. And you know, I think that they you know, need to be educated a little bit in what this whole concept is. You know, many lay people don't really know about this. They've had no exposure to ICUs. They've had no exposure to ventilators and technology. And at that point, I think it's even reasonable to talk about the term brain death. Some people don't like to do that and use rather the declaration of death on the basis of neurologic criteria. But I think in common vernacular, these terms have become sort of interchangeable. And, as we progress to talk about the brain death exam, I mentioned that, we will be consulting experts in this area who are the pediatric neurologists, and that they will be doing a very thorough examination to examine for all the functions of the brain. And I sometimes draw a figure, not a figure, a little schematic of what a brain is. And I talk about, I have a little circle that's the cerebrum, and I say, this is the part of the brain that's responsible for consciousness and movement. And then I've got a little bit coming down, that's the brainstem, and I say, this is responsible for functions of the nerves to the eyes and the pupils. And lower down this is the area of the brainstem that makes us breathe. And then lower down the spinal cord, talk about this is the area that's involved in our reflexes that we test, and they've done that. And so that's sort of how I progress. I think, we'll then get the neurologists to come and meet the parents, and they will formally do the exam. The one thing that I think is very important is that, and useful, and is for the parents to be in the room when these brain death exams are conducted. I think there's nothing more profound and impactful than when this apnea test is done and the parents see that the child doesn't breathe for 10 minutes when the ventilator is removed from the child. And I'm sure we'll talk more about that. But does that sort of cover it? I've kind of hogged the time.
Yes, thank you. And then often throughout this process, Emily, as part of the palliative care team, you meet with the family and help them sort of work through everything that they're hearing and what's happening in these hours and days. Can you tell us about your involvement?
Absolutely. So as Ivor mentioned, there can be a lot of information dropped on families in a short period of time. In our case scenario, in addition to just her child being in the ICU with a severe brain injury, she's also, lost the father. And so there's so much going on with families outside of this incredibly intense experience with their child that we kind of have to get a feel for, to understand really and truly what are families hearing, what do they understand, and what should our next conversation be. And every family is a little bit different. There's no one script that fits everyone. So I kind of go in and just kind of ask questions. What have doctors told you? What are people saying? Just to get in their words, their perception of what's going on. What are you most worried about? What are you hoping for? Some parents already jump to, I know she's gone and I just don't know how to tell my, brothers and sisters, right? Versus she's moving. I really don't understand why the doctors are saying her brain's not working. So you can get a good idea of where a family is just by asking simple questions. The other piece too is to try to figure out the right formula of when to share all the information. Sometimes just saying we have to do tests to make sure, see what parts of your child's brain are working, and this is called a brain death exam, is all the family can hear. Other families want to jump all the way to steps 3 about what is a brain death exam, how many do you do, what does it mean, and what do we do afterwards. And so for those families, you dive more into the details about what things look like, and you don't have to take it a step at a time. So figuring out what formula matches the coping skills and the information needs of your family at the time can be helpful for the primary team to be most effective with how they use their words and how they use their time so that the experience is least traumatic as possible.
Thank you. Matt, your team is often involved either by request of the family or as another support service. What do you talk about with families, and what do they want to talk about with you?
It kind of depends on the family, or a lot of it depends on the family, the context that they bring with them. If they're a family that comes from some sort of faith-based or religious background, then some of what they want to talk about with me is sometimes it's very practical questions, but sometimes it's really big picture questions of why would God or whomever allow this to happen? Depending on their context, they might come at it from a perspective of, as opposed to the way that this case is presented is, mom wants to delay because maybe she'll get better. They'll come at it with no, you can't make any decisions because God is going to perform a miracle. So then that is its own sort of set of topics and conversation to engage, is helping, because similar to what Emily talks about, is so much exploration about what is it that they're bringing to this, like what framework are they bringing to this? And it might be a faith-based framework, or it might be just sort of their general belief system that they're trying to, what I witness is they're trying to see this thing that makes zero sense that's in front of them. And they're trying really, really hard to make sense out of it with what they already showed up with. And I think that's the biggest challenge. I think about, as Ivor mentioned, and I think Emily mentioned too, like this family has experienced so much in such a short amount of time. And now it's fallen to the mother, who is the decision maker, who has lost a spouse, which may mean that has lost income, which may threaten housing, which may threaten food, which, who knows all the losses that are accumulating from that pathway at a minimum, like functionally has lost a car, may have to move, who knows what all the impact that has on it. And so it makes all the sense in the world that while a kid is having some sort of automatic reflexes in front of her, that she would stand in the way and say, oh no, let's not have this lost too. Right. And so I frame a lot of the way that I work with people in this situation is around the grief that they're experiencing and the losses that they've faced. Because I firmly believe, like, we're not going to get her past all of these losses to be able to make a decision. But whenever all she can see is all of these losses that are in her face, it's going to be hard to have a conversation with her. And so, I mean, as you were describing that initial conversation, I've sat in that room with you and seen just like the dull glazed over look that a family might have, because there's just so much has changed. And now we're giving them a medical education about how brain works. And so I guess the shorter version of my answer, April, is to try to be present with them where they are. And similar to Emily, trying to get a good assessment of where they are so that I can work with them and advocate on their behalf to try and have whatever communication they need as this case is going to progress.
Thank you. And Lisa, as the neurologist, sometimes we get involved a little bit later after we have evidence of this severe irreversible injury, sometimes at the time of starting the brain death evaluation process. And so you're coming in and they've had exposure to various concepts so far. And so how do you approach the conversations with the family and what comes next?
And so I think we're really lucky at Hopkins in that we do have multiple layers of support. And one thing that is really important before we kind of walk into a room is trying to understand the context in which that's happening. So really appreciate conversations with people like Ivor, Emily, and Matt, who have kind of been going through this process with the family. And it really helps you to understand where you're coming into the situation. But then, of course, reassessing where the family is, trying to understand how best to be an ally to them. And sometimes that is like they feel like they've had their questions answered. They sort of know that their child is never going to be the same again. And we're more of like the person coming in and just doing the exam, and that happens. And sometimes that's the way to be supportive. But more commonly, it's, kind of walking through walking through things in more detail, but certainly for everybody when coming into it, I want to, obviously answer any questions the family has, provide as much support as they want or need. And then kind of explain to them what's going to happen during the brain death exam, and certainly, encouraging them if they feel up to it to be in the room during the exam. And some of the things we do during the exam are very noxious and are very can be very distressing. So preparing the family for the things that they're going to see if they stay in the room, I think is very helpful. And depending on where the family is, really explaining to them beforehand and then during the exam why you're doing what you're doing, what you're looking for, I think can be really helpful for these families to sort of help them understand and give them some sort of closure. Like Ivor kind of gave the example of their child not breathing for 10 minutes. Similarly, sort of every aspect we're doing, they can kind of see in what detail we're looking for any kind of brain function in their child. So I think that is very helpful. And then I think that there's a lot of kind of ways to sort of phrase things in a way that they can understand. So I really like to, before I do the exam, kind of talk about what reflexes we might see that could be present, but not indicate brain function. Because I think it's really hard for families to, like, we're looking for movement and you see a reflex, and then they're like, I've had families like celebrate before, and then you have to backpedal and say, actually, that's a spinal reflex that comes from the spine. So getting ahead of those and saying, like, every movement we see, we have to determine where it's coming from, and we'll walk through that as we go. So I like to introduce that before we do the exam as well.
Thank you. As a corollary to this question, we've talked about a lot of very technical things. Are there specific phrases or language that each of you find can be particularly helpful, either about brain death as a whole or the process that they're going through?
This whole time I've been thinking about a case that I was involved with where the child was brain dead as a result of an accident. And they were a very faithful Christian family that had a pretty black and white understanding of medicine and of life, right? And I remember that the phrase that the physician was able to offer that really kind of turned a corner for them, it was not your child will never be the same child that they were, right? It was because the family was holding on to, well, God will take them when God is ready. And this is kind of a classic line that we sometimes see in ICU. And to be able to say, God has already taken them and we have artificially kept them here, right? And it's a hard thing for people to say. It's a hard thing for people to hear. But for that family, that really, it was upsetting, but they caught it in a different way because I know that I've been witness to a lot of these conversations of attempting to explain all the medicine and the science, but with that framework of we are artificially continuing their life and really helping a family understand it made sense for them.
That's a great example, Matt. I think we could give lots of examples of this, but just in the interest of time, I want to move on to the next question, but hope maybe we might be able to get back to it at the end. So what is the process if families do refuse the evaluation, or the evaluation is done, but they disagree with the determination of death and they refuse to allow removal of the ventilator and other technologies? Ivor, do you want to talk about the options that come next?
Sure. I just wanted to add one thing to what Matt was saying when you were talking about words to use and so on. I think the one thing that becomes very important is not to use the word, after you have made a declaration, not to use the word life support, but rather to use the respirator rather than life support, because otherwise you're giving mixed messages. And the other thing that I think we haven't raised so far that's important is at some point when you're explaining the issue of brain death, is to mention that after the declaration that the ventilator will be discontinued. Because that, I think, needs to be explicit, that the declaration of death will have been made, and then the respirator will be stopped, not life support, because that gives very mixed messages. So, you know, as to your other question, is sort of what do we do when we're faced with a family like this who is reluctant to believe what we are saying, that in fact the child has died on the basis of neurologic criteria. And you know, this is a hard position for all of us to be faced with. It's difficult, terribly difficult for the family, and it's difficult for caretakers. But I think we have to take a deep breath, we have to sit down, and we have to explore. And this is, again, a meeting which needs to take place with our medical team, but as well as with the clergy, as well as with social workers, as well as with Emily and her group. And the important thing is to explore what is the basis for this refusal? Where is this family coming from? Is this religious? Are these are members of a religion that don't accept brain death, that don't expect brain death? Some of, you know, Orthodox Jews, some Orthodox, very religious Muslims or Shintoists. You know, try to understand where this is coming from. What have they heard? Have they, you know, heard about a case where this happened and the patient survived? You know, have they had a previous experience? And I think this is very important and a difficult issue to explore. You know, is this an issue where they feel that they're giving up if they do this, if they accept this? You know, clearly they are grappling with this huge loss, and sometimes they need more time just to wrap their hands around this horrible experience. You know, I think our move needs to be one of providing some accommodation. You know, I think amongst caretakers, there's a sort of a spectrum of how people think about it. Some people I think are more rigid, and as soon as the declaration, well, you know, if they, well, in this scenario, we're not going to get to that point because we haven't done a brain death exam. But I think we need to make accommodation. I think this is the important part. It's more time to explore with the family. I think it's very important for the family to get their community leaders to come and meet with the team, to get their clergy to meet with the team. You know, we have to go through this process together with members of their close community.
And I think what you're highlighting there, Ivor, is that in the majority of families with a little bit more time and exploration of their reasonings, we're able to come to a consensus and move forward.
Yes, absolutely.
But occasionally, rarely, thankfully, there are times when that time and conversation doesn't work.
Yes, I just want to mention that, April, you had mentioned the revision of this UDDA that is sort of in process now. The Uniform Law Commission is currently meeting and will be meeting through the year. They're a group that provides recommendations to the UDDA about laws that get adopted by the state. And there's a real push in that group now as regards accommodation. So I think people will be free to be less pushy about withdrawing the ventilator at that point. Just to mention that there's one state, that of New Jersey, where the accommodation has gone to such an extent that they allow people to essentially opt out of being declared dead by neurologic criteria, and then the healthcare system is obligated to continue with the ventilator. Okay.
And so in the policy, the recommendation is to get in touch with risk management or legal if you cannot come to a consensus with the family or don't have a pathway forward. The other hospital resources are the ethics consult service. Will often meet either with risk management or independently from them, as well as there is a determination of death by neurologic criteria support team, which is made up of adult neurologists and intensivists, but can work together, especially in cases where the determination might be unclear or there's not a clear pathway forward. So all of those are hospital resources that are available. There have been times where we've had someone come from outside to do an independent examination when if the family felt that they wanted their own physician or someone that they trusted to give a second opinion. So there are many pathways forward, but risk management and the ethics service can help in these cases. And in a similar vein, what resources are available to families who are coping with this traumatic loss of their child and grieving process? And maybe Emily and Matt, you can talk about what you offer and then as well as other resources.
So sadly, their formal resources for bereavement are scarce within our community, and funding for programs is something that is not necessarily I guess prioritized might be the right word or come into focus. No one is sad, but no one wants to think about children dying. So having resources for people who still have to bear the reality of that loss is something that is just now coming to the forefront of our culture and is something that's important. So we do have bereavement resources that we mail for any child who dies in the Children's Center. Their family gets packets throughout the year with books. There's opportunities for support groups with other families who have lost children in our Children's Center. We have an annual tribute service where parents can come and remember their child and be amongst other people who have suffered similar losses. Between our team and social work, we try to connect with bereavement therapy therapists through community-based hospice. They are a good resource and are willing to provide grief counseling on a sliding scale basis. So there's ways in which between us and the social work department, we try to independently fit families with the resources we do know in our community, but there's not a lot out there from how we desire to care for families after their child dies.
Muted. All right. Thank you all. These are some of the references for the conversation that we've had regarding the definition of brain death, how it's identified, particularly in pediatrics. For those who are in the Hopkins system, this is a link to the new health system policy that goes live this week. And an interesting article about some communication strategies to use for neurologic prognoses. I'd like at this time to thank all of our panelists for coming and sharing your various experiences and the work that you've done taking care of patients in this unfortunately tragic situation, and the things that you do to ease their grief. I'd like to open things up for questions. We have about 5 minutes. Please feel free to put your questions in the chat or the Q&A. and we'll address each one of them. We have one currently. The distinction between spine and brain seems central. Is there a crisp, unambiguous definition of each? And maybe Lisa, you can talk about how you go into a little bit more detail about how you explain brain function versus other reflexes to families.
Yeah, so there's some very well described spine reflexes that I think we sort of like to get in front of. So something called triple flexion, where you're going to triple flex at the hip, knee, and ankle, kind of all at the same time, is a very common spinal reflex that we see and that we can sort of demonstrate beforehand. And we can kind of like we wouldn't necessarily go into the detail with family, but things we're looking for in our exam are very stereotyped nature of the response, and that with stimulation, even in different parts of the body, you will get the same response. And so those are ways that we as neurologists can tell those things apart. And then things like deep tendon reflexes or Babinski reflexes are things that are all spinal mediated. So those are really important to know. And so in general, there's kind of clear, crisp categories, but I will say that I've definitely been in situations where there is some kind of ambiguous response, or it's being seen by members of the ICU team or nursing, or there's kind of some level of ambiguity, and that can really be difficult, and we can kind of take various approaches to that. One approach is just sort of giving it time and saying, like, we're going to wait, we're going to like reassess in the morning and see, like, are those responses still there? Because oftentimes those will evolve over time. And then in the kind of most extreme case, sometimes we'll do ancillary studies if we don't know, but in the vast majority of cases, we can sort of tell these are coming from the spine, these are coming from the brain.
And just as a little bit of a follow-up to that, going back to your earlier question, April, about what are words and phrases that people use that we've witnessed help families. I have witnessed that preparation from your teams of neurology and the ICU teams to help people understand what they're going to see makes such a difference, because when that preparation's not been put in place well, then, as Lisa said earlier, they see somebody take an agonal breath and the family celebrates, or they see somebody's hand move and the family celebrates, and that it's not like we've not anticipated the movements that they might see. And those can be a devastating time to watch a family, because they suddenly are sort of reinvigorated with hope, but it is only making it a more complicated scenario.
And the follow-up question is there an anatomic definition that maps to clinical findings? The spinal reflexes can be very complex movements, and the more complex they are, the more difficulty we have explaining them. But trying to think of all the ones that I've seen and read about, they all really should occur from the neck down. The most dramatic is called the Lazarus sign, where the entire body can almost sit up in bed. You can see arm and leg movements, and that when it's elicited, it's very rare, but when it is elicited, it's usually from neck extension. And so we can talk about how they should map on to some sort of innervation through the spinal cord. They really shouldn't involve any cranial nerves or anything in the face, although I don't think there are, but I'm not sure that I'm 100% accurate, because they could be very complex. Hopefully that helps answer the question. All right. I think this brings us to the end of our time. For those who joined late in the chat, you'll find the code and the number for CME credit if you would like to claim that for today. Thank you all for joining us for this discussion about pediatric brain death or death by neurologic criteria. And I hope you all have Thank you again to our panelists who did a wonderful job. I hope you all have a wonderful day.